Episiotomy is indicated only for specific circumstances. It should not be done routinely. Episiotomy can be done with a vertical incision called a median episiotomy. Repair and anatomic results are excellent and blood loss is minimal, but if a tear occurs, it may extend to the anal sphincter. The incision can also be angled 30 to 60 degrees laterally, called a mediolateral episiotomy. The further the perineum bulges, the more the angle stretches and thus increases. Bleeding is greater and repair is more difficult, but tears are less likely to extend to the anal sphincter. Before making an episiotomy incision, provide sufficient analgesia using regional anesthesia, a pudendal nerve block, or local anesthetic infiltration. Insert 2 fingers under the fourchette to protect the fetal head from the scissors. Make a vertical incision stopping at the perineal body. The perineal body can be easily identified during a rectovaginal exam as a tight band between the posterior vaginal wall and rectum. To repair the vaginal laceration, first assess its depth. First-degree tears involve only the skin. Second-degree tears, the usual depth after an episiotomy, involve the muscular layer too. Third-degree tears involve the anal sphincter, shown here in white. Fourth-degree tears extend to the rectum, the layer below the anal sphincter. Do a rectovaginal exam using a pill rolling motion to assess the integrity of the anal sphincter and rectal mucosa. Third and fourth-degree tears should be repaired by experienced providers. Begin repair after the placenta is delivered and bleeding is controlled. Ensure proper patient position, good lighting, and adequate analgesia. Begin by placing an anchor suture at the apex of the vaginal epithelial laceration. Use 2O or 3O absorbable suture material. Then continue to repair the vaginal epithelium using a running locked suture and avoid taking wide bites, which would tend to contract the wound and narrow the vagina. Also, avoid placing sutures too deep. If sutures reach the rectal epithelium, infection and rectovaginal fistulas can result. At the junction of the vagina and perineum, insert a transition suture. Now at the perineal level, use a running suture to close the muscular layer. The outer bite of these sutures should be at the junction of the skin and muscular layer. This closure decreases tension on the perineal skin. After closing the muscular layer, Insert a transition suture and then close the perineal skin using a running subcuticular suture and moving in a cephalad direction. Complete the closure at the level of the vaginal introitus, then insert and tie a final suture inside the vagina. Do a digital rectal exam to make sure that sutures do not involve the rectum.